Good morning, everyone. Today, we'll discuss growth hormone deficiency, GHD. This condition results from insufficient secretion of growth hormone, GH, by the anterior pituitary gland. Although GH is well known for promoting growth in children, its functions extend far beyond increasing height. It also plays a vital role in protein synthesis, lipid metabolism, glucose regulation, bone remodeling, and maintaining muscle mass. Therefore, GH deficiency produces different clinical manifestations depending on the patient's age. Today's lecture will cover causes, clinical features, diagnosis, treatment, adverse effects, contraindications. Causes. Let's begin with the causes. The most common cause of GH deficiency in adults is damage to the hypothalamic pituitary axis. Remember that GH secretion is controlled by two hypothalamic hormones. Growth hormone releasing hormone, GHRH, stimulates GH secretion. Somatostatin inhibits GH secretion. Therefore, disease affecting either the hypothalamus or the pituitary gland may reduce GH secretion. Common causes include 1. Pituitary tumors. Pituitary adenoma are the most common cause. As the tumor enlarges, it compresses the normal pituitary tissue, decreasing GH production. 2. Treatment of pituitary tumors. Ironically, treatment itself may cause GH deficiency. Examples include pituitary surgery, cranial radiotherapy. Both may damage normal pituitary cells. 3. Other causes of hypopituitarism. These include traumatic brain injury, pituitary apoplexy, infiltrative diseases, congenital pituitary abnormalities. One important point is that isolated GH deficiency is relatively uncommon in adults. Most adult patients have multiple pituitary hormone deficiencies because the same pathological process usually affects several hormone-producing cells. Clinical features. The clinical presentation depends on whether the patient is an infant, child, or adult. Infants. Let's start with infants. Growth hormone is involved in maintaining blood glucose during the neonatal period. Therefore, deficiency may cause hypoglycemia. Normally, GH opposes insulin. It increases hepatic glucose production and decreases peripheral glucose uptake. Without GH, infants are more prone to hypoglycemia, especially during fasting. Micropenis. This occurs in male infants because GH works together with gonadotropins during genital development. Micropenis may be one of the earliest clues suggesting congenital hypopituitarism. Children. Children present quite differently. Their main problem is impaired linear growth. Growth failure. Normally, GH stimulates the liver to produce IGF-1. IGF-1 acts on the epiphyseal growth plates of long bones. When GH is deficient, IGF-1 decreases. Chondrocyte proliferation slows. Long bone growth decreases. Consequently, the child becomes progressively shorter than peers. Delayed skeletal maturation. Growth hormone deficiency causes delayed bone age, delayed skeletal maturation, delayed closure of the growth plates. Bone age is usually assessed by an X-ray of the left hand and wrist. In GH deficiency, the bone age is typically younger than the child's chronological age. Adults. Adults no longer grow in height because the epiphyseal plates have fused. Therefore, GH deficiency mainly affects metabolism. Let's discuss each feature. Increased fat mass. GH stimulates lipolysis. Without GH, fat breakdown decreases. Fat accumulation increases. Patients particularly accumulate visceral fat, which contributes to cardiovascular disease. Reduced lean body mass. GH promotes protein synthesis. When GH is deficient, muscle protein synthesis decreases. Muscle mass decreases. Muscle strength declines. Patients often complain of weakness and poor exercise tolerance. Reduced bone mineral density. GH stimulates bone formation through IGF-1. Without GH, bone turnover decreases. Bone mineral density falls. Fracture risk increases. Dry skin. GH stimulates collagen production. Deficiency causes thin skin, dry skin, reduced sweating, reduced energy and poor quality of life. Patients often complain of fatigue, lack of motivation, reduced exercise tolerance, depression, impaired concentration. Quality of life is one of the major reasons for treating adult GH deficiency. Increased cardiovascular risk. GH deficiency causes increased visceral obesity, elevated LDL cholesterol, endothelial dysfunction. These changes increase cardiovascular risk over time. Insulin resistance. The relationship between GH and insulin is complex. Although GH acutely increases insulin resistance because GH has anti-insulin effect on glucose, so it decreases glucose uptake by the cells, chronic GH deficiency also often leads to increased fat accumulation and metabolic syndrome, which are themselves associated with insulin resistance. Diagnosis. Diagnosis is challenging because GH secretion is pulsatile. A normal random GH level tells us very little. Therefore, we use two approaches. Serum IGF-1. Instead of measuring GH directly, we measure IGF-1. Why? Because GH fluctuates dramatically throughout the day. IGF-1 has a much longer half-life and reflects the average GH secretion over time. If IGF-1 is low, GH deficiency becomes more likely. However, normal IGF-1 does not exclude GH deficiency, especially in adults. Approximately 1/3 to 1/2 of adults with confirmed GH deficiency may still have normal IGF-1 levels. Dynamic GH stimulation tests. These are the cornerstone of diagnosis. Insulin tolerance test (ITT). This remains the gold standard. Principle. We deliberately induce hypoglycemia using insulin. Hypoglycemia is a powerful physiological stimulus for GH release. In healthy individuals, GH rises markedly. In patients with GH deficiency, GH fails to increase adequately. The textbook uses a cutoff of 3 nanograms per milliliter, which is acceptable for learning purposes. In modern practice, however, the exact cutoff varies according to the assay used and current clinical guidelines. Important note: obesity reduces GH responsiveness, making interpretation more challenging. Epilepsy and ischemic heart disease are contraindications to ITT, because hypoglycemia may provoke seizures or myocardial ischemia. Therefore, these patients usually undergo alternative stimulation tests. Alternative stimulation tests. If ITT cannot be performed, alternatives include glucagon stimulation test, arginine-based stimulation tests. The choice depends on local availability and institutional protocols. Treatment. Treatment consists of recombinant human growth hormone. Since endogenous GH is deficient, we replace it with recombinant GH. Administration is by subcutaneous injection, usually once daily. The dose is individualized according to age, body weight, serum IGF-1, clinical response, adverse effects, indications. Treatment is generally recommended for patients with confirmed severe GH deficiency, impaired quality of life, appropriate replacement of other pituitary hormone deficiencies. Before starting GH therapy, deficiencies of cortisol and thyroid hormone should be corrected, because untreated adrenal insufficiency or hypothyroidism may worsen after initiating GH replacement. This is an important clinical point because GH interacts with both the adrenal and thyroid axes. The concern is not that GH causes adrenal insufficiency or hypothyroidism, but that it can unmask or worsen deficiencies that were previously compensated. Cortisol, adrenal insufficiency. Some patients with hypopituitarism already have ACTH deficiency, resulting in low cortisol production. When GH therapy is started, GH increases the conversion of cortisol to inactive cortisone by reducing the activity of the enzyme 11-beta-HSD1. As a result, the amount of active cortisol decreases. If the patient already has borderline cortisol deficiency, GH therapy may lower cortisol levels enough to produce symptomatic adrenal insufficiency or even precipitate an adrenal crisis. Therefore, cortisol deficiency must be diagnosed and treated first, usually with hydrocortisone replacement. Thyroid hormone hypothyroidism. GH also affects thyroid hormone metabolism. It increases the conversion of T4 thyroxine to T3, the active hormone. This increased conversion can lower circulating T4 levels. Because the pituitary cannot produce extra TSH, the thyroid cannot make more T4. T4 falls further. The patient may become clearly hypothyroid. This is why we say GH therapy can unmask central hypothyroidism. Therefore, levothyroxine replacement should be started or optimized before initiating GH therapy, and thyroid function should be monitored after GH treatment begins. The clinical rule. Think of GH as increasing the body's metabolic demands. If the patient already has untreated cortisol or thyroid hormone deficiency, their body cannot meet those increased demands, and the deficiencies become clinically evident or more severe. Benefits of treatment. With successful therapy, patients experience reduced fat mass, increased muscle mass, improved exercise capacity, increased bone density, improved lipid profile, better quality of life. These improvements develop gradually over several months. Adverse effects. Most adverse effects result from fluid retention, sodium and water retention. Patients may notice ankle swelling, mild weight gain, puffiness, carpal tunnel syndrome, fluid accumulation around the median nerve causes, numbness, tingling, nocturnal hand pain, arthralgia and myalgia. Patients may complain of joint pain, muscle pain. These symptoms often improve after reducing the dose. Hyperinsulinemia. GH antagonizes insulin. Consequently, some patients develop hyperglycemia. Worsening diabetes control. Monitoring blood glucose is therefore important. Benign intracranial hypertension. This is uncommon. Patients develop headache, blurred vision, papilledema. Fortunately, it usually resolves after discontinuing GH therapy. Contraindications. GH therapy should not be given in active malignancy. Because GH and IGF-1 promote cell proliferation, GH replacement is avoided until the malignancy has been successfully treated. Benign intracranial hypertension. Treatment should be postponed until intracranial pressure has normalized. Proliferative diabetic retinopathy. IGF may promote retinal neovascularization, potentially worsening advanced diabetic eye disease.